to this great meeting. Thank you, the JWICC and AHS Organization Committee. My talk today about advances in interventional therapy for coronary artery disease, Western and Asia experience. Of course, the journey of interventional cardiology, it is a very long over the last decade and last century actually. And of course, the turning point in this treatment of coronary artery disease through intervention is the 1977 when Andreas Granzing did the first BTCA for proximal LED in 16 September 1977. Since that time, there is a revolution in the interventional field actually. My agenda today, actually, it is AMI with cardiogenic shock, what's new, invasive strategy for ACS in a daily patient, and complete revascularization and stable STEMI, DCP use and strategy, and the intracoronary imaging as well. Of course, there is recently data published through Shock CAD registry showing the real-life data about the prevalence of causes of shock in the AMI. Actually, it is majority of AMI cardiogenic shock due to STEMI, 77%, and the non-AMI cardiogenic shock, it is actually due to heart failure, 36%. And this is the most common devices used for the support of cardiogenic shock, intra-aortic balloon, Impella, and the smallest portable ECMO device, CardioHelp system. The VA ECMO actually, despite its benefit, but there is major drawbacks, which is increasing the afterload actually. And this recently published ACLS shock trial, including more than 400 patients divided into two groups, 209 with ACLS and 208 with medical therapy alone. And the primary endpoint after 1 year follow-up, all-cause mortality. Of course, all results was comparable, not significant differences between the medical therapy and ACLS therapy, and the all-cause mortality is nearly comparable, 55 for the ACLS, 55.8 for the medical therapy, and no differences in all-cause mortality clinical outcomes at 1 year. Then coming the Impella CP and Impella 5.5, where there is direct unloading for the LV, which is severely impaired and severe in heart failure. Coming the danger shock trial, which is a landmark trial, actually took nearly 10 years to complete after exclusion a long list of cases and randomization of the cases into Impella group 180 and the standard of care 180. Then the results was significant differences in mortality at 6 months with reduction in the Impella group to 45%. But at the cost of the raising of the complication, vascular complication in the microaxial flow pump group with absolute risk reduction 12.7 and all-cause mortality 26%, with secondary composite cardiac endpoint significant differences between both groups in danger shock trial. And this comparison between the SLS shock trial and the danger shock trial showed that the SKY classification stage E, it is much more common in the group of the SLS shock trial, 32 patients, while in danger shock trial, it is only 15 patients. Also, the lactate level on admission, it was a little bit moderate elevated in the danger shock trial, while it was extremely high, 6.8 in the SLS shock trial, as well as the MCS use initiation before BCI. In more than 84% of the cases of danger shock trial, the initiation of MCS before BCI, while it is only 21% in the SLS shock trial. Then coming the intra-aortic balloon, also, which is having the great impact in the reduction of the afterload and increase coronary perfusion. Then coming this year, the ALT shock trial, which using the intra-aortic balloon early for heart failure related to cardiogenic shock, nearly 100 patients, 53 intra-aortic balloon, and 48 patient. 48 patient pharmacological therapy. And the result of the trial actually negative, as all result of the intra-aortic balloon it is no significant differences in terms of survival probability and survival or successful bridge to LV assist devices or heart transplant at 60 days, but even at the cost of increasing the complication rate, bleeding, vascular complication, limb ischemia in the arm of the intra-aortic balloon actually. So alt-shock trial demonstrate early intra-aortic balloon implantation does not improve 60 survival or bridge to heart replacement therapy in heart failure and shock. Then this year also the Asian Pacific Society of Cardiology consensus statement given a very important and simplified, applicable approach for the recommendation of cardiogenic shock MI patient where the stage A and the stage B, where there is a still lactate in the normal level below 2, of course, in these cases, we should go directly for immediate revascularization. While in the stage C, stage D, where there is elevation of lactate and LVDB more than 18, cardiac index less than 2.2, so we should go for early support of the cardiogenic shock actually, then we can go also for early revascularization in those group of patients, incoming the extreme cases of cardiogenic shock where lactate can be extremely high, nearly 8, so support and resuscitation is very crucial for this very simple and applicable approach in this new guidelines. Then also coming this year, the 25 concise American College Cardiology for cardiogenic shock, which actually recommend early MCS application, and the early revascularization is very crucial for saving the patient. And the guidelines coming this year and making downgrading of the intra-aortic balloon. It was 2A in 2013. This year it is a class 3 recommendation after Calvert shock trial, after FIT STEMI trial. It is contraindication to be routinely used in the cardiogenic shock actually. And VA ECMO also after the SLS shock trial, after ECMO CS trial, it is a class 3 recommendation after this negative results of this trial. But for the Impella, it is upgraded from class 2B to class 2A recommendation after the landmark danger shock trial. And for mechanical complication in the setting of acute coronary syndrome, still the recommendation class 2A for using of intra-aortic balloon or even Impella for the support of such cases. As regard to revascularization in the setting of cardiogenic shock, still the American College Cardiology recommendation, a class 1 for culprit only revascularization, and the class 3 for multi-vessel in the setting of cardiogenic shock. And this is actually the this year recommendation. We transfer to another very important issue, complete revascularization in a stable STEMI patient. Of course, we have long list of data from primary trial, Calvert trial, angio-guided trials, then coming dynamic cerebral multi, complete, compare acute and complete trial, FFR guided BCI for non-Calvert lesion in a stable STEMI patient. But this year coming, the 10-year outcome of complete dynamic cerebral multi, 10 years follow-up of this study, actually showing significant differences in the outcome with still complete separation, and benefit persist for more than 10 years in this complete revascularization guided by FFR in this study. But the question for complete revascularization in the setting of stable STEMI, what is best time for revascularization? Is it immediate or a staged revascularization? Actually, one of this important study coming from the European Society of Cardiology Congress this year, what's called option STEMI trial. It is actually from 14 sites in South Korea, 994 patients after a primary BCI with Calvert lesion, randomization to immediate complete revascularization, and in hospital staged after a few days hospitalization. And the primary outcome will cause death and non-fatal MI, and the results actually not fulfilled the non-inferiority. It is negative trials actually for the benefit of immediate revascularization in comparison to the staged revascularization in a stable STEMI patient. And it is harmful even in subgroup analysis with patient heart failure, CALB class 2 or CALB class 3. And of course, the study recommendation is in favor of staging approach for a stable STEMI with multivessel disease in the same admission index. This actually comparison between the option STEMI trial, which is negative, and the BioVasc trial, multi-star trial, which is actually positive result for benefit of immediate revascularization. It is actually contradiction between the data coming for using of complete revascularization in a stable STEMI patient in the same admission index during primary BSI. So still the American guidelines recommend complete revascularization to be an immediate stage, class 2B recommendation, while in staging it is a class 1A recommendation to be done within a few days from admission. So we transfer to another important issue also, the invasive strategy for elderly patient actually. It is a very difficult group of patient. All the geriatric comorbid conditions are associated for patient more than 70 years old. And it is a challenge actually. Most of the patients having heart failure, renal insufficiency, stroke, frailty, cognitive impairment. And this is a statement from the American Heart Association says that the management of acute coronary syndrome in elderly patient is much more complex than younger population due to anatomical complexity, physiological vulnerability, age-related risk, and heterogeneity. And coming recently, the Seniorita trial actually, where they study the invasive procedure for elderly patient in STEMI more than 75 years old and 753, and conservative management in 765 patients with follow-up showing that the primary outcomes of the study are composite of cardiovascular death or non-fatal MI, comparable between both groups of invasive and non-invasive strategy in elderly patients beyond 75 years old, p-value 0.53. And the secondary points still is the same, comparable results between the cardiovascular death, MI, and major bleeding between both groups, and the conclusion of the study that invasive strategy, it is safe to be applicable for elderly age group of patient. Then coming this year also, the follow-up 3 years of the FIRE trial, complete versus culprit-only BCI in elderly patient, where there is physiological guided complete revascularization, the inclusion criteria, 75 years old, MI, STEMI or non-STEMI, multivessel disease, after successful BCI of the culprit lesion. Of course, randomization into physiological guided complete revascularization or culprit-only revascularization in patient elderly more than 75 years old with follow-up after 1 year and 3 years and 5 years. This year coming the 3-year follow-up results, it is significant differences in terms of reduction of all-cause death, MI, stroke in the invasive group actually. And this conclusion that physiological guided complete revascularization in elderly patient more than 75 years old, it is actually safe and lowering the endpoint of death, MI, stroke, and the benefit sustained over 3 years follow-up and safety, reliability in the stent used in this study is efficient in this elderly age group patient. And also coming the Benelux IVL study using the lithotripsy for treatment of calcified lesion in elderly patient beyond 80 years old with randomization 147 patient more than 80 and 403 6 patient less than 80 years old, and the results most commonly use imaging in the younger age group, not the elderly age group, and the results is comparable between the elderly age group in terms of the technical outcomes and 1 year adverse outcomes, and also the 1 year major adverse cardiac events. It is comparable and no significant differences between the elderly age group patient and the younger age group patient, and the results of this study demonstrate excellent safety and efficacy of using of the IVL in calcified lesion even in patient advanced age more than 80 years old. Then also very important issue this year about the use of DCB. We know the benefit of DCB. It is actually very important for short debit use, no metals, no polymers, no side branch closure, no risk of stent thrombosis. One of the most important drugs used is paclitaxel and sirolimus. And this statement coming also from the Asian Pacific Consensus Group also recommend that optimal lesion preparation is the key for success for using of DCP. Once you prepare with a one-to-one balloon ratio, whether using the non-NC balloon or the angioscalped or the scoring balloon or retoplation, atherectomy, whatever according to the imaging results. Of course, if the result accepted and stenosis residually before you use DCP less than 30%, so it is candidate for DCP, and if FRF more than 0.75%, it is candidate for DCP. Otherwise, you can use the drug-eluting stent in these cases. And also coming this year, very important data about DCP in the bifurcation lesion, using after provisional stenting of the mean vessel, then using DCP for the compromised side branch using 784 patients. Compromised side branch after provisional stenting, more than 70% into two group, DCP group and NC balloon group. And the criteria, the lesion should be very short, less than 10 millimeters, and the compromise of the lesion more than 70 degrees, and the lesion, the vessel size more than 2.5, and the results coming 1 year composite target lesion failure. It is actually significant reduction of all this target lesion failure in terms of cardiac death, target vessel MI, clinical driven TLR in the DCP group for the side branch compromised after mean vessel stenting in this group. So in bifurcation lesion after compromising of side branch with short lesion, we can use DCP safely and effective results after that. Then coming the ultimate trial also where the IVUS guidance versus angiography guidance during DCP angiography in de novo lesion, 260 patient angiographic guided group and IVUS guided group for DCP 130 patient. The results actually in segment late lumen loss at 7 months was associated with lower in segment late lumen loss in IVUS guidance group in this study. Also the Sepelent in-stent stenosis randomized trial comparing the sirolimus and paclitaxel, and of course the outcomes in terms of target lesion failure and composite endpoints and clinical driven TLR is comparable between sirolimus and paclitaxel, showing that the in-segment late lumen loss and in-device late lumen loss also is comparable. So this novel sirolimus is non-inferior to the paclitaxel group in this study. And reform study also for DCP use comparing the piolimus and paclitaxel. Of course, the 135 DCP piolimus and 67 paclitaxel, and the outcomes actually does not meet the non-inferiority, and it is failed to show the non-inferiority of the piolimus to the paclitaxel group. Then coming this year also from USA, the agent IDE trials, which is the first DCP approved in USA, and this agent used randomization 2-to-1 agent DCP for balloon angioplasty and the follow-up 1 year and 2 years, and the clinical characteristic comparable between both groups as regard to diabetes even and the multi-layer of the stent in those groups, and the primary endpoints of target lesion failure at 1 year. It is very highly significant for using of DCP in the in-stent stenosis group. And the definite probable stent thrombosis at 1 year also, it is very highly significant, 0% thrombosis in this group. And the subgroup analysis for the use of the DCP in 2 stent layer of the in-stent stenosis, showing significant impact of this DCP in a group with 2 layer in terms of target lesion revascularization and target lesion failure, more effective in the multi-layer in-stent restenosis. And coming this year, follow-up after 2 years, showing still persistence of target lesion failure, differences between the 2 groups of patient and TVMI and the definitive probable thrombosis. And it is very efficient to use the drug-coated balloon for in-stent restenosis. Finally, this is the last just a few slides. Of course, there is a complete change from the guidelines. It is now in the last recommendation that imaging, it is mandatory to be used in complex anatomy. European guidelines, American guidelines, this year coming to clear recommendation, class 1A recommendation for complex anatomy, and it is clear from this recent guidelines, and China using imaging in 23 according to these papers, and Japan is the most common used imaging trials. And this one of the important study about using the Calypso trial for calcium using OCT versus angiography guided in calcium according to the predefined algorithm, extension arc less than 180 or 180 to 270 or extension more than 270, and of course the successful geometrical expansion, major malposition, all are significant expansion of the stent in the OCT guided group. So it is better outcomes with OCT guidance for calcified lesion. So my final take-home message: early mechanical circulatory support and early revascularization in AMI cardiogenic shock is crucial. Only culprit artery revascularization AMI with cardiogenic shock to reduce mortality and renal failure. Staging complete revascularization still it is a class 1 in stable STEMI with multivessel disease rather than the immediate, which is indicated in some specific cases. And invasive strategy in elderly ACS patient is safe and efficient, especially if it is guided with FFR or imaging or DCP or IVL use. DCP, a new efficient tool after good lesion preparation with intracoronary imaging guidance to avoid stent-related cardiovascular events, and IVAS or OCT is highly recommended in the complex anatomy like left mean stem, true bifurcation, and long lesion. Thank you very much.